Okay, and it looks like we are 2 after the hour, so we can begin. Hello, and thank you for joining our July MMS Info Session. These sessions are offered under the CMS Measures Management System contract led by Battelle. I am Kate Buchanan, and I support the education and outreach efforts on this project. Today's session is a testing topic roundup on several measure testing problems and solutions. These info sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics. And among the activities that we do are annual public webinars on high priority CMS topics. At the end of this presentation, you will hear a little bit more about our August public webinar, which will be on the Digital Quality Measurement Strategy Roadmap. I would now like to turn it over to Mel Gross from CMS to provide welcoming comments. Mel?
Good afternoon, everyone. Thank you for coming. As Kate said, my name is Melissa Gross, and I am the task lead for the Measures Management System contract, and I hope to be able to facilitate the conversation today if need be and help to answer any questions. And I'm so glad that you could make it to join our info session and learn about measure testing problems and solutions. Thank you. Back to you, Kate.
Thank you so much, Mel. And we can go on to the next slide. So before we jump into today's topic, I do want to cover a few housekeeping items. First, today's session is being recorded. Second, all participants will be muted during the call. You can enter questions into the Q&A feature. We will have an opportunity for Q&A at the end of the call, but we encourage you to submit questions throughout the presentation. The Q&A window is at the bottom of the side of your screen, and if you're having difficulty seeing it, if in the lower right portion you click on the 3 dots, you should be able to select Q&A, and that's how you would submit questions. Finally, throughout the meeting, we will share resources in the chat window, which is above the Q&A. You should see a link for today's slides, as well as registration information for the August public webinars. The recording of today's presentation will be posted to the CMS Hub at a later date. So, today's session will focus on a handful of specific testing-related topics that emerged from this year's Measures Under Consideration list submission process and interactions with measure developers. These are 3 separate topics that will not address all commonly encountered testing problems. And as you find while you're listening to this discussion, there are other testing questions you would like to learn more about in a future session. We highly encourage you to email us at mmssupport@battelle.org. So next slide. So here we have the 3 questions that we will discuss, and they are: which interclass correlation coefficient variation is most appropriate to assess reliability? What is person encounter level data? And are there standardized ways to evaluate quality measure feasibility? I'm now going to turn it over to my colleague, Laura Ami. Laura?
Hello. Yes, so in today's session, we are going to discuss the interclass correlation coefficient, which is a common statistic that's used to represent the reliability of a measure. Not sure if there we go. So the reason we do reliability testing is to determine, one, that the data elements are likely to produce consistent results when drawn from the same population that's not changing. And second, to ensure that the score is precise. And precision can be representative as if you think of, for example, if you had a confidence interval around a score, if that confidence interval is extremely wide, then the measure is, and maybe too wide to be practical, then that measure score really isn't very precise. So reliability addresses that as well. Another application of reliability would be for inter-rater reliability, which tests the consistency between raters like abstractors and coders. So reliability also refers to error that is associated with a measure, as for example, signal versus noise, or the measure error divided by the total error of a measure. So reliability values, they range from 0 to 1. So a very unreliable measure that is absolutely completely inconsistent or very imprecise would have a value of 0, and 1 if it's something is a completely 100% correlation or 100% getting the same answer every single time would have a reliability value of 1. So the values closer to 1 is what we're going for with getting a very strong measure of reliability. And again, the reliability is the measure of the true variance of the measure over the variance plus other error that's attributed to, for example, sample size. And the interclass correlation coefficient is one measure of reliability, and there are others. It does reflect the correlation agreement between measures, and it's better than, for example, historical methods such as the Pearson correlation coefficient, because it actually incorporates a rater bias that wouldn't be incorporated in a Pearson correlation coefficient. So one rater could be giving a completely different but perhaps consistently higher rating than another and still get a very strong correlation coefficient, but the ICC does adjust for that. So there are different types of reliability. There's inter-rater, which is just how well do two different observers agree on the same measure. The intra-rater, which would just be if a same rater evaluated perhaps the same entity at different times, different subject at different times, how well that rater is consistent within themselves. And then also another would be test-retest, which is often used to measure reliability. Basically using the same response under different at different time periods or something like that. And then I think this is what we're getting to here is that there are a lot of different variations of the ICC that could get different results when applied to your same data set. So you need to be sure that you're using the one that really does correspond to the format of your data. So here's a table, and it's sort of a table that summarizes this the different types down to a little more concise. So there are the type of model. So you may have a random or mixed effects model, and then the form is the number of raters. So you may have, in some cases, you may only have one rater for each of your subjects. Or you may have multiple raters, and so that is the form. Now, the important part here is you may have multiple raters when you're assessing your measure, but if you're really going to be using in the actual application of the measure that you're only going to rely on one rater, then you really still use the form 1, even if you have multiple raters that you're using to assess your measure. So that form corresponds to how that measure will be used in the application. So a one-way random model is a model that that would have only one measurement per subject, but possibly measured by different raters. Each subject may be measured by a different rater. So you really don't have any way to compare the raters. You just have really, you can only compare the different subjects and get an estimate of how consistent the measure is. A two-way random effect, now you've introduced, you have a subject is one of your factors, and then the raters would also be, you'd have multiple raters for each subject. So each subject would be measured by multiple raters, and each rater would rate each subject. But those raters are a random effect, which means that theoretically your raters have been drawn from some population of similar raters. And then the two-way mixed model is a little bit of a subtle bit of difference when each rater is actually only is a specific rater of interest. And that would be, it's less common really to have this situation where you are only interested in the result of those raters, and they're the only ones that are ever going to be rating rating this measure. And this is, I would say, a less common application. And then there are different ways of calculating that ICC based on those. And that there was a reference to a Koo and Lee paper that was on a previous slide. And that paper would give a lot more details about how each of these interclass correlation coefficients would be calculated based on the particular situation. So another measure of reliability is signal to noise, and that's calculated in a different way. It's explained in this Adams paper, and it's using the estimating the proportion of the variability that can be explained from the differences in performance between the entities by calculating the measure variance and then the total variance. And there are many cases where an ICC or this signal to noise could both be calculated, and they give slightly different results. And so here at Battelle, we are working on some assessment to kind of determine what the results of each of those would be and what the relationships and differences are. And so that's underway to kind of clarify the relationship between those two statistics. So now at this point, I would like to hand you over to Sam Simon, who is at Mathematica, to talk about data element terminology.
Excellent. Thanks, Laura. Hey, everyone. Yep, I was asked to talk a little bit about data elements and data element terminology. So we can go to the next slide. So really, one way to think about a data element is that they are the building block of quality measures. Quality measures, of course, are composed of several components, those components being the numerator, denominator, and exclusions or exceptions. But each of those components will be made up of one or more data elements, which forms the basis for each measure. So really, every measure can be broken down into its data elements, which consist of specific codes for either encounters, patient characteristics, devices that can be applied or ordered, diagnoses, medications, symptoms, lab tests, and interventions. So actually, one way to think about this is to take an example. I'll take a very basic example. CMS 349 is a measure of HIV screening, and it's the description of the measure is essentially the percentage of patients who are 15 to 65 who also were tested for HIV in that age range. So for that measure, the measure for the denominator component, the data element would be a patient characteristic, in this case, age. The numerator component, the primary data element here is a laboratory test. So we'd be looking for a code indicating that a HIV test was administered. And this measure happens to have an exclusion. So that data element would be a diagnosis, that diagnosis being a diagnosis of HIV. So in summary, each measure component, each numerator, denominator, and exclusion is made up of one or more data elements. And so when we think about validity for data elements, we're thinking about the accuracy of those data elements. Reliability for data elements refers again to, just like Laura was talking about, reproducibility of the results. For some kinds of measures, particularly eCQMs, data elements in an EHR are going to pull the same codes. And this is, of course, one of the benefits of relying on an EHR as a data source, because there's a single definition for that data element, for example, a diagnosis, and it's always going to be provided, consistently, so that reliability becomes a little bit less of an issue for data elements that are drawn from eCQMs. Let's move to the next slide. So something to be aware of is that the terminology around data elements is changing. Data element testing is now, as the slide talks about, is now referred to as person/encounter level testing by the consensus-based entity, which is currently the National Quality Forum. So when you see references to person/encounter level testing, you should think about data elements. And this, of course, is in contrast to testing at the measured entity level, which is typically the clinician group, hospital, nursing home, et cetera. So just something to be aware of. And I think that change in terminology may have caught some folks off guard. So just something to be aware of. Next slide, please. So the guidance that the NQF provides is that all critical person/encounter level elements should be tested. So what does that mean? What does critical data elements mean? Essentially, to demonstrate that a measure is valid, all the clinical data elements should be tested for validity. If it's in the specification, it should be tested. One notable exception here would be encounter codes, which are a little harder to validate, but all other data elements, such as patient characteristics, devices applied or ordered, diagnoses, medications, symptoms, lab tests, interventions, all can be validated. The most commonly accepted approach to test data element or critical person encounter level data elements is to compare the data element to something that could be considered a gold standard, and evaluating that agreement between what comes out of what the measure of data element is and that source of truth. So for eCQMs, this is typically done by randomly selecting a sample of patients and comparing data elements that are electronically extracted from an EHR with a manual chart abstract that uses the entire EHR. The idea here is really that sometimes structured EHR fields may or may not be an accurate representation of care. The manual abstraction will often pick up data that may be embedded in non-discrete or non-structured fields, such as physicians' or nurses' notes. And so when we're looking at agreement, the preferred statistic to use here to look at agreement between the extract and the chart abstract is to look at kappa, which is not the same as overall agreement. Kappa adjusts for chance agreement, whereas overall agreement does not. In addition to kappa, sensitivity, specificity, positive predictive, and negative predictive values are also useful to generate where mismatches occur. So that is a few words about person encounter level elements. And I'm actually happy to pass it off to the next speaker, feasibility.
Thank you, Sam. Feasibility is one of the measure evaluation criteria, and Laura talked about another measure evaluation criteria, which is reliability, and that falls under a grouping of scientific acceptability. And Sam talked a little bit about reliability and validity of data elements. Feasibility addresses the data elements for the most part. You can go to the next slide, please. All measure must have feasibility checks. The earlier in the measure development, the better. But you don't just, it's not a once and done. You continue checking feasibility throughout the measure development and maintenance process. So, I mean, here's the definition of what feasibility is. I'm not going to read it to you. You can get this information on the MMS Hub. You can find it by going to the Blueprint section and go under Measure Testing. From there, go to Testing and Measure Evaluation Criteria. And on the left navigation, you'll see the different measure evaluation criteria, of which feasibility is one. So, yeah, okay, thank you. I was going to ask for the next slide. So how do you address and assess feasibility? Well, there's no one way, but you do need to dig into the clinical workflow. And since most hospitals and clinicians are now using EHRs, you need to look at the data collected in the EHR. So generally, the feasibility assessment should address these items: availability, extent of missing data, cost, burden of data collection, barriers without violating the patient confidentiality, and identification of unintended consequences. Now, some of those are a little trickier than others. But again, there's no one way. And on the next slide, we'll give you one example of one way you can. The CMS CBE, previously announced as National Quality Forum, has created an eCQM feasibility scorecard. And it assesses 4 things: data availability, data accuracy, data standards, and workflow. And this is the download is actually an Excel spreadsheet. And it's a pretty easy form to use. You list your data elements, and then you answer yes or no to each one of the 4 items. And then you repeat again for every EHR health IT system that you're using. You test each one that you're using, because it's rare to find an EHR health IT that 2 systems that are exactly alike. And note I said EHR or health IT system. While we commonly associate eCQMs with EHRs, they do not have to rely only on data found in an EHR. That, however, is a topic for another day. Next slide, please. While the name is eCQM Feasibility Card, there's no reason you cannot use that tool for non-eCQMs. And given the push towards digital measures, the likelihood of a new chart abstracted measure is unlikely. Consider the latest draft of a digital measure, which is use 1 or more sources of health information that are captured and can be transmitted electronically via interoperable systems. And some examples that they provide are of the data sources are administrative systems, electronically submitted clinical assessment data, case management systems, EHRs, laboratory systems, prescription drug monitoring programs, medical devices, wearable devices, and patient-generated data such as home blood pressure monitor or blood glucose monitoring, health information exchanges, registries, and anything that's considered electronic data. So keep your mind open about where you're getting your data. But remember, it's got to be feasible. You got to be able to find it. It's got to be accurate. Best if you have standards for the data element. And is it collected while you're doing your normal care? Next slide, please. So another possible method for testing feasibility is using the Systems Engineering Initiative for Patient Safety, or the SEEPS model. And just a little background on the SEEPS model. It is a model of human factors and ergonomics developed by Pascal Karayan and her colleagues, and they first published in 2006. It has its basis in work balance model and the Dunn-Abedian structure process outcome model. It has undergone several iterations since 2006. And while its name includes patient safety, it is more broadly applicable. It has been used to understand or design socio-technical systems and has supported evaluation, planning, and research activities. Dr. Karayan was awarded the John M. Eisenberg Award in 2015 for her individual achievement and excellence in promoting patient safety and quality care with the SEEPS model. The Eisenberg Award is a joint award given by Joint Commission and NQF annually, and they give them usually in 3 areas: individual achievement, national level innovation, and local level innovation. So one way to use the SEEPS model is to use a PET scan. In this case, it's a PETT, meaning people, environments, tools, and tasks. And I refer you to the supplement of the document that's article that's referenced at the bottom of the slide. It's got a really good set of templates and lots of good information. So in this model, people are the individuals or groups of people and their physical, cognitive, and psychosocial characteristics. The environments are settings of activities internal to the unit of analysis or the surrounding external context and the characteristics and influences of these environments. Tools are the objects of varying technical advancement used to transform an input into an output, and the characteristics of these tools, technologies, devices, artifacts, which gets into a little bit of usability, which is another measure evaluation criteria. Tasks are specific activities assigned or performed within a broader work process and the sequence and characteristics of those tasks. The PET scan then looks at the interactions between the 4 factors, which are factor-to-factor combinations and ways factors interact, such as how well a tool fits a task or how the social environment affects a person's behavior. While the eCQM scorecard looks at workflow, the PET scan could go a little deeper. For example, get you to whose workflow. Who is doing the data collection, as the workflow may vary from person to person or professional type to professional type. The PET scan also gets into barriers, something not addressed by the eCQM scorecard. Tools could be data availability and so on and so forth. So the eCQM scorecard and the PET scan of the SEEPS model are only 2 possible tools that can help assess feasibility. The key is to address all those items that are back on slide 15, or maybe it's not 15 anymore. But with that, I am going to thank you for your attention, and I will pass it back to Kate. Thanks.